Welcome to Access Amplified, the podcast where we shine a light on how digital health is increasing access to care and advancing equity around the world. I'm your host, Joanna Brownold, and our podcast is brought to you by ChristianaCare. In each episode, we sit down with healthcare leaders who are doing the work, not just reimagining access, but actually rebuilding it from the ground up. Today, we're joined by Dr. Sarah Schenck, Executive Director of ChristianaCare's Center for Virtual Health. Thank you so much for joining us today, Dr. Schenck.
Thanks, Joanna. It's great to be here.
Dr. Schenck is a practicing primary care physician who has led some of the most innovative virtual care programs in the country, from hospital at home models to early employer-driven virtual primary care. And we're going to talk about the different range of services that ChristianaCare offer and how they're impacting access to care in Delaware. So let's get started. Let's start with your approach to care delivery. You've spoken about the idea of high frequency, low intensity care. Can you explain what this means and share how it underpins your virtual care strategy?
Yeah, so I am a primary care physician, as you said, and for years would really be frustrated trying to take care of my patients in the traditional model, which is seeing our patients once or twice a year. The patient comes in with 6 to 12 months worth of problems they've sort of saved up. And then I too, as their primary care physician, have an agenda. You know, I have preventative measures that I want to make sure I go over with my patient and check in with some of their lifestyle behaviors, et cetera. And it's just really hard to address all of that in one 20 or 30-minute visit. And so at the end of that visit, neither of us leaves feeling particularly satisfied, like we've achieved what we needed to achieve. And so I thought of this other model, which is high frequency, low intensity. So instead of having an office visit once or twice a year, I want to stay connected to my patients. It doesn't need to be in person. In fact, it's probably better that it's digital, that it's virtual, that I'm texting my patient just like I do my family and friends.
Mm-hmm.
And that way, as they have issues, concerns, questions, we can address them right then and there. And we don't need to save it up for 6 to 12 months.
So how does that not make it very high intensity for you?
It makes a much lower intensity because instead of trying to address 13 problems at one time, we're really just addressing the one problem or two that they have at the moment. And the other part of that is that it really takes a team. I do believe that healthcare, particularly primary care, is a team-based sport. I call it, share the care. And so not every question and concern that a patient has needs to be addressed by me personally. And in fact, sometimes it's better addressed by others on my team. So if it's a side effect question about a medication, my pharmacist on the team is probably better equipped to handle questions like that. So it's really about activating the right member of the team at the right time for the patient to get what she needs.
Yeah. Okay. That makes a lot of sense. And I think what I really want to do is you have quite a wide range of virtual care programs, which is really special about what you're doing at ChristianaCare. So I want to try and dig into a couple of those in a little bit more depth today. And I want to start with your virtual primary care program, which even started before the pandemic. So you were way ahead of the curve and still are, I think. What inspired ChristianaCare to launch that program in 2018, and what has the evolution of that program looked like since?
So ChristianaCare is the largest private employer in the state of Delaware, and we're actually self-insured, which means that we are responsible financially and otherwise for the health of all our employees. And so we really thought to ourselves, what's the best way to take care of our own? Better, faster, cheaper. And it starts really with primary care. And we thought, let's do primary care in a different way to see if we can better serve our own employees. And so in 2018, we opened our virtual primary care practice, really meant for our own employees.
Mm-hmm.
And then when COVID came in March of 2020, that team pivoted literally overnight to become a virtual COVID clinic and to take care of patients across the state and beyond with acute COVID concerns. And the team started to grow and evolve. And then we thought, how can we extend this virtual care delivery to people outside of our employee base for primary care? And so since 2020, we really have been serving other patients in virtual primary care. We have a couple of business lines. One is a direct-to-consumer line where patients actually pay a subscription rate, generally monthly rate, to be a part of the practice and to have all the amenities and access that our employees enjoy. We also work with local employers, other employers, because we figured if this program worked well for ourselves as an employer, it's bound to work for others, and it does. We do have an arrangement with other employers too.
Okay. And I think, I mean, I find it really interesting how you were able to kind of pivot that so quickly overnight. That's a very fast moving mindset, which isn't necessarily always the case for health systems.
I do think that the virtual venue, because of the nature of its agility, really allows us that flexibility, adaptability. We can stand up clinics overnight, quite literally. And, we can also take them down. So one example is we opened up a monkeypox clinic when there was a epidemic in our area for monkeypox. And we leveraged all the right people on the team and all the right resources. And we treated exactly 2 people in that clinic. And then thankfully, the epidemic died down and there was no longer demand. And we just dismantled the clinic overnight. So it's a great way for us to sort of rise and meet the demand at the time, and then realize really quickly, you know what, I guess this demand isn't as strong as we thought it was. And it's okay for us to dismantle it and try something else.
And I think a lot of that kind of trying and seeing, that's a really efficient way to test out new concepts, right? Because if you're doing it digitally, you don't have to, deal with brick and mortar challenges that would happen. Have you ever seen a case where, you opened a digital facility or a digital project or program and then saw that there was huge demand and translated that into a physical service?
You know what? We've actually done the reverse, which is we had a bricks and mortar, we had a concussion clinic, which had a really large no-show rate. About 50% of the time patients didn't come to their appointment. Well, that's not surprising because most people with concussion can't drive. And so transportation was definitely a barrier. And we saw that in that clinic. And so we virtualized that clinic and made a virtual concussion clinic, which has basically 100% show rate. I will say that virtualizing something, in my mind, doesn't just mean turning an office visit into a video visit. I mean, really, all bricks and mortar practices, certainly within ChristianaCare, and I would venture to say in most health systems, offer video visits in addition to in-person visits. And that's really important. But that in and of itself, I wouldn't call virtual care. Virtual care really is about that in-between care, the care that patients are getting from us when they don't have an appointment. And that is where we lean into the technology. And so in our virtual primary care practice, for example, we text our patients. We use a platform called Twistle, which is a HIPAA compliant texting platform where we can have bidirectional conversations with our patients to stay connected to them so that we don't need to wait for a visit in person or video for the patient to get the care that they need.
Okay. And are there other digital tools or workflows that you've found that make your virtual primary care model work really well?
Yeah. So for virtual primary care, there are a couple of workflows that we created to promote better access, a better patient experience, and frankly, better outcomes. And so one of those is the 4-2-1 rule. And that's a rule that probably our patients don't know exists, but we sure do. And we hold ourselves accountable to that. And so the 4 stands for quarterly. We reach out to our patients, and this is all automated through the Twistle platform. And it's just a light touch that says, this is Dr. Schenck's practice reaching out to you. How are you doing? Thumbs up or thumbs down? And you can say thumbs up and go about your day, or it's an opportunity to say, actually, I'm experiencing, this condition, or I need a refill on this medication, or whatever your need is at the time. It's an opportunity to have that conversation with the care team. So that's the 4 and the 4-2-1 rule. Twice a year, the nurse on the team reaches out to the patient to go over their care plan. And we can talk about the care plan in just a minute. And then once a year is the visit that patients have with their primary care provider. Now, those 7 touches are minimum. So we want all our patients to have all 7 of those touches every year. But in fact, when we count, our patients on average have 12 meaningful encounters with us every year, which
Okay.
is much more than you would see in a bricks and mortar model.
Because they're initiating them as well.
That's right. That's
Okay.
right. That's right. And then the other thing we believe in virtual primary care, frankly, primary care, is that everybody deserves a care plan. Typically, we reserve those care plans for patients who have, really a burden of many comorbidities, chronic diseases, patients who come into the hospital and emergency room a lot. But actually, even quote unquote healthy people deserve to have a plan to even be healthier, to get better. And so we call that plan Working on Wellness, or WOW plan. And everybody in our practice has their own WOW plan. It is digital, it's on their portal, it's right there when they log in, front and center, and it's personalized to that patient. And it includes 3 components. One is if that patient does have chronic diseases such as diabetes, it will remind them of actions they need to take care of their diabetes. The second is preventative care reminders, getting their mammograms and their colonoscopies. And the third is the wellness. And we really focus in on sleep and diet and exercise and mindfulness. And so we set goals with our patients so that they hold themselves accountable to those goals. And when the nurses on the team are checking in with them twice a year, that's what they're going over. The last thing I'll say about the WOW plan is it is sort of a to-do list for patients. It's very overwhelming when patients leave the doctor's office and they have all these forms and orders and they're not sure what to do in what order. And so this is a nice streamlined recipe for them to follow for better care. But it's also actionable in that it not only reminds patients that they need a mammogram, but it gives them an opportunity to book it right there. Or to
Okay.
say, when I lived in Kentucky last year, 6 months ago, I had it done. And it lets us know, what, you're not due yet. So it's actually a very interactive tool for patients to use. And it's been able to allow us to see what our patients need and follow their outcomes. And we have closed many care gaps using this tool.
I mean, that sounds amazing. That's really the dream for me, is for somebody to give me that, right? This is tailored to you. This is a step by step how to look after yourself, how to live a healthy life, not just to address problems as they arise. And then, as you said, that's going to close care gaps and that's going to encourage healthy lifestyles, which is good for you and it's good for your patients.
That's right.
That's fantastic. So kind of shifting gears a little, the other virtual program that's really kind of one of your flagships is your hospital at home program, hospital care at home. So can you tell me a little bit about that, what it looks like and what kind of outcomes you're seeing?
Sure. Yeah. So our hospital care at home program opened in December of 2021.
Okay.
And the waiver, the CMS waiver was made available, I think it was November of 2020. And ChristianaCare applied for our waivers in the summer of 2021. So in about 6 months, we built a virtual hospital. We worked with, at the time, their name was Medically Home. They're now Dispatch Health, and they were really pivotal in helping us build this virtual hospital. And we built it from the ground up. We hired everybody, we trained everybody, we used the Medically Home technology. And then we went out in December and found our first patient. And since then, the program has grown tremendously. At the beginning of the program, at any one time, you might find 0 to 2 patients on census, right, at their homes getting care from us. And today, it's 10 to 15 patients.
Okay. Wow.
And we've cared for almost 2,000 patients in this model, in the hospital care at home model. It turns out that, the outcomes that we're realizing are no different than the outcomes that are sort of being realized nationally in other systems across the US. First, I'll say that patient experience is outstanding. Patients prefer to receive care in their home amongst their loved ones and their pets, perhaps in their favorite bed or their cozy chair, often eating their own food. They tend to heal faster, and it's a more enjoyable, satisfactory experience for them and family overall. So that is something we have definitely seen. The second is by keeping patients out of bricks and mortar hospital, we're able to avoid some of the facility associated complications, like infections and
Yeah.
like bacterium. And so we do see very, very low rates. In fact, knock on wood, this year we've had absolutely no
Wow.
infections at all.
Wow.
We've had no mortality at all since we've been live. So it's a very safe venue of care in the home, actually, and we're definitely seeing that. The third outcome that I really want to highlight is what happens to patients after they're discharged from the program. And so a few things we notice is that when patients start at home, they tend to stay at home.
Okay.
So bricks and mortar hospital, when we look at patients who met all the criteria for our program, but simply declined the invitation. So we're really comparing apples to apples. About 20% of those patients go to a skilled nursing facility after discharge.
Okay.
In our program, it's about 1%.
Wow. That's a
So
massive,
really, yeah,
difference.
it's a big, frankly, savings for the system who's paying for it, but more importantly, for the patient to be able to stay at home and recover.
Right.
So that we're noticing. And the second thing we're noticing in the post-acute space is a significant reduction in readmission. So patients are much less likely to need to go back to hospital within the 30 days of
Okay.
discharge. We tend to see single digits for readmissions, 8, 9%, whereas nationally it's about 15, 20 plus percent, depending on the condition. So that's something too. And those data sort of bear out across the country for this
Which,
program.
I mean, that kind of follows through, I guess, kind of ties back into that ongoing care piece. So I'm assuming, even just psychologically, like if I've managed to get myself through and recovered well at home, I'm less likely to say, well, actually, I need ongoing care. I'm independent now. Like you're also empowering your patients as well, not just physically, but mentally as well, to say, I can get through this. I can look after myself now.
That's exactly right. We also use some of that high frequency, low intensity care with our patients who have been in the hospital. And so for that 30-day period following their hospitalization, we do stay connected to them digitally to make sure they have the medications they need, they have their follow-up appointments that they need, that they're getting the care that they need in their home. And if they're not, we're able to intervene right there and then rather than have them come back to the emergency room looking for something.
Right. So it's kind of keeping people out of hospital, not just temporarily, but like for an ongoing.
That's right.
That's great. And how do you determine which patients? You mentioned that there are some people who kind of decline to be part of the program. How do you determine who to invite in the first place?
Yeah. So, when we opened our program, I'm really kind of proud of the fact that we decided not to limit it to certain conditions. We really think it's less about the condition; it's more about the patient and their home. And so, in the first 20 patients we admitted, they had 20 different diagnoses, actually.
Wow.
So we take care of more common things. So that would include respiratory infections, pneumonia, COVID, congestive heart failure, COPD exacerbation, cellulitis, the sort of the things you might expect. We certainly see more of those, but we do a wide range of conditions. It's really, do we think the patient could be taken care of safely in their home with whatever condition they have? And is their home a safe place for care to happen? Both for the patient and for our colleagues who are going into the home physically, because this is a hybrid program. So it's part virtual, part in person, and there definitely are caregivers going into the home every day. And we want to make sure it's a safe space and that expectations are set around, for instance, firearms and pets, et cetera. So once we do that and make sure that the patient lives in the right location, for our program, they need to live within 25 miles of one of our campuses.
Okay.
Then we invite them to join the program. It's really their choice if they want to stay in the bricks and mortar hospital or if they want to go home.
And do you have like uptake numbers on that?
Yeah. So, patients are just starting to learn about this venue, about this model of care. It's pretty innovative and new can be scary for
Right.
people. And so when you say to a patient who's come into the emergency department because they're ill, and you say, guess what? You can turn around and go home and we're going to bring the hospital to you. They're incredulous. And so it's been a learning journey for all of us. It's definitely change management. It's helping not only our patients and families understand, but also our other doctors and clinicians in the hospital understand it's really okay for us to take this patient home.
Mm-hmm.
So that's been an evolution. Today, because we've taken care of 2,000 patients, often we'll find patients in the emergency room who've either experienced this program themselves or a loved one or a neighbor. It's starting to become more familiar to
Right.
people. And so I anticipate that more and more people will accept the invitation when offered. The other thing is we have a tremendous data analytics team here at the Center for Virtual Health, and they help us understand not only who's in the hospital and in the emergency department at any one time, but who might be the best fit for our program.
Okay.
And so they've literally developed a homegrown tool that sort of spits out a report every morning for us to understand where should we go first, how should we prioritize this, and who might be the best fit. And they're now using AI and machine learning to iterate on that. And we may learn that, Pisces who live on a road with a hill are best for our program. I don't know what we're going to learn, but we're
Okay.
out to learn exactly who is the best fit. The other thing I'll say is, we serve all of the communities, surrounding communities, and they range from very sort of impoverished communities with few resources to the other end of the spectrum. We actually monitor and track that. We use the area of deprivation index, the average area of deprivation index. So
Okay.
1 is a neighborhood that is incredibly resourced, high education rates, employment rates, et cetera, and 10 is the other end of the spectrum.
Mm-hmm.
And we look at where our patients are, and it's not just tracking zip codes. It's literally down to the individual neighborhood. So within
Wow.
one zip code, you may have people who live in 1 and people who live 8, 9, and 10.
Right.
So we're tracking that. We're geocoding all of our populations and really understanding. And we found something pretty interesting. We found when we looked at patients by their average area deprivation index, the patients who lived in that 8, 9, 10, the
Mm-hmm.
ones that are deprived, frankly,
Yeah.
of resources and access to care, they actually did better in the program. They actually had lower readmission rates and better outcomes in the program.
Okay. Do
So
you do you
that's
have a
interesting.
hypothesis as to why that is?
Yeah, no, I think that this program is great for addressing social determinants of health. I mean, there's nothing like going into somebody's environment to understand what
See?
their environment is like and
Yeah.
how we can help them and help them, right? That particular person. It's really powerful. And I always say to my team, we want to leave a house nicer than how we found it. And so if somebody, one of our very first patients had a pretty aggressive ulcer. He was a diabetic with ulcer. He actually ended up needing an amputation. And he had terrible lighting in his home, and we weren't able to conduct adequate exams on camera. So we brought in lighting to his home so that we could do that. And he got to keep the lighting at the
Okay.
so, we really try to make everybody's home environment conducive to this and to healthy living in general. And
Mm-hmm.
so I think being able to go into the home and really address the social determinants of health affords us better outcomes.
Yeah. That's great. And that's really like coming back to kind of taking that individual, building a plan for them and seeing how you can improve their lives. And this is obviously doing that on the ground, which is not always an opportunity that we have.
That's right.
And you mentioned, obviously this is a hybrid program, but you have programs that are fully virtual. You have programs that are in home, hybrid. What have you learned about when to go virtual, when to go hybrid, and kind of which model best fits?
Yeah. It's a great question because they're all slightly different, aren't they? And they require different resources and workforces. I would say I really see the emergence of 2 new healthcare workforces that I didn't see when I was in training. One of those is the virtualist workforce, and those are
Mhm.
our caregivers who are working in our command center and seeing patients on video. That's its own workforce, and I liken it to when I was in training, there was a new workforce that emerged, and that was called the hospitalist workforce. So when I first started out in training, the primary care doctor went to the hospital, made rounds on her patients,
Right.
then traveled across town to her office and saw her ambulatory patients. At the
Right.
end of the day, traveled back to the hospital and saw her hospitalized patients. Turned out we couldn't continue to do that. That just didn't work for the patient or the doctor. And so we created a new workforce called the hospitalist workforce. And we have specialists who live in the hospital with their patients, and they're there all day, not just at 7 a.m. and 5 p.m. I think the same is true of the virtual workforce. I think it's going to take a dedicated, specially trained workforce who is trained and educated on delivering care virtually. The other workforce I'm seeing grow is not new, but I'm really seeing tremendous growth in it, is the in-home workforce. And those are our home health nurses, therapists, people who are accustomed to going into the home and delivering care and meeting patients where they are. I see that workforce growing tremendously over time. One thing we've learned, and this is an interesting example, we mentioned the virtual primary care practice that we started in 2018. When we opened that practice, it was 100% virtual. And the number one question we got from people was, what happens when you need to be seen in person?
Right.
And the truth of the matter is, over the first 3 years, I can count on two hands how many times that happened. It's just we were able to partner with other people in the community. If somebody need an abscess drained, we could send them to the surgical office. If somebody had a true emergent issue, we sent them to the ER.
Right.
We just didn't find it to be a barrier. But patients had a perceived barrier. They didn't want to join this practice for the fear that they wouldn't be able to be seen in person should that need arise.
If they needed, yeah.
So we evolved the model to be virtual first, so that we do now include in-person option. We literally rent space, a little exam room that we use a few days a week, and we're able to see patients in person should that arise. But actually, we don't use all the time and slots in that space.
Oh, wow.
We
Okay.
haven't used it. So it's more of a perceived need than an actual need. But we're always learning and trying to understand, what our communities and patients need from us, and we're able to sort of adapt the model accordingly.
Okay. And you've kind of mentioned a couple of times some of the specialty virtual clinics. And I know you have a behavioral health one, which I think is really something I'd like to touch on because, I think we all know that behavioral health lends itself well to virtual care, but you're doing things a little bit differently. Can you tell me a little bit about that, about your group-based therapy model and what you've learned from that?
Yeah, so we opened up in 2021 a long COVID clinic, our COVID recovery clinic, virtual COVID recovery clinic. And we did that again because our community needed us. There was not such a clinic in the state. And we felt like we needed to do that. So we opened up our doors. It was actually May 4th of 2021. And started taking care of long COVID patients. And we quickly realized that these patients, in addition to the medical care they were receiving from our team, needed behavioral health support. These were patients who were suffering a lot of symptoms and, frankly, disability, and felt sort of unheard, and felt kind of marginalized as a community. And we really felt like there needed to be a separate venue where those patients could safely be together and be heard and hear each other. And so we created a long COVID recovery support group, which is facilitated by our clinical behavioralist. And she just Dr. Centrella does a phenomenal job bringing our patients together in a safe space. And they do it virtually. So just imagine a Zoom call with 10 people, and they can be in the comfort of their own homes. A lot of our long COVID patients have difficulty with mobility and endurance and stamina. And so it makes sense that they access care right from their couch.
Right.
And we learned that this particular group of patients really found power and healing in the cohort. And this idea that they were coming together every week to share their stories was really, really remarkable to see. And so we ended up opening a second cohort that met at a different time.
Okay.
And that's been running since 2021.
Wow.
And then it made us think, well, there's probably other conditions that would lend themselves to this group model. And so we did one, for instance, in the holidays around holiday stress for our employees. So that
We all need that.
yeah, exactly. But that there is power in the group for sure. And it's not for everybody. We do obviously offer one-on-one
Hmm.
therapy as well. But we find particularly for our long COVID patients that they really enjoy the group therapy.
Okay. I can kind of, I mean, we do a lot of webinars and I do a lot of moderating of those webinars, and I can imagine it must be tricky to um, moderate 10 people on a Zoom call when they're all looking to share. But they're really finding value from that,
That's right.
which is really special.
That's
So I've got a question for you now, for you personally. You've been with Christiana Care for over 18 years. What keeps you inspired, and what are you most proud of in the work that you're doing now?
I would say, what keeps me inspired is that there's so many opportunities in healthcare. And,
Hmm.
we're all here at Christiana Care, we're all caregivers, we're all in some way delivering that care. But we're all patients at some point too. And we all
Yeah.
experience healthcare either directly or via a loved one. And we all see that there are problems in the health system. It's frankly broken, right? And we have problems with cost, we have problems with access. And there are just so many opportunities. And I'm a problem solver. And so I see that as a great opportunity uh, for solving problems. And
Hmm.
what I tell my kids, what I do is it's about the quadruple aim. It's about better outcomes, better experience for caregivers and for patients. It's about lowering costs, yes. But quite simply, it's just making care better for everyone. Making care better for everyone. And I think what I'm most proud of is, I'm not, this is a little dirty secret. I'm not sort of tech savvy. I'm the one that joins the Zoom meeting on mute. I don't ask my kids. I'm not tech savvy. So it's super ironic that I'm running
Yeah.
a company. But but here's what I am. I'm incredibly passionate about delivering excellent care and about making care better for everyone. And I think I'm proud of being able to be part of that through the Center for Virtual Health, through my amazing team, and for Christiana Care to support that journey. I'm just so grateful.
I think if you can admit to saying I'm not tech savvy, but I'm leading virtual care for Christiana Care and doing these amazing programs, then there's really no reason that my mom can't get onto Zoom next time I try to show her the kids' drawings. So or any of us can't access care really virtually now. So thank you so much for joining me today. This has been a really great conversation.
No, thank you so much. My pleasure.
I'm just so impressed by, the range of offerings and the range of offerings, but also coupling that with the personal care plans and the personalized care that you're providing. It's an amazing balance. So thank you very much for sharing that. If you enjoyed today's conversation, please be sure to subscribe or follow wherever you get your podcasts. New episodes drop every 2 weeks. Please share this episode with a colleague who's passionate about digital health access or rethinking care delivery. Access Amplified is brought to you by Taito Care. I'm Joanna Brownold. Thank you so much for listening, and we'll see you next time.